Stop grabbing that thing. Okay, it looks like we are officially live on Facebook. Thank you everybody for joining us. We'll just go through with some introductions with our hematologists that we have here today. If everybody else wants to state who you are and where you're from. And thank you for joining. So go ahead, Marshall, you can start.
Great. Well, thanks everyone for joining. I'm Marshall Mazepa. I'm a hematologist. Treat adult patients primarily at the University of Minnesota. Anna, I'll hand it off to you.
Anna? Okay. I'm Anna Antun. I am at Emory University and I am benign hematologist focusing in TTP.
Hello, everyone. I'm Metjian. I'm a hematologist with a clinical and research interest in TTP. And I'm a hematologist in the University of Colorado in Denver, Colorado.
Radhika, thanks for joining us. Yeah, why don't you just give us a quick introduction?
Yeah. Hi, good evening. I'm Gangaraju. I'm a benign hematologist at University of Alabama at Birmingham with clinical and research interest in TTP.
Great, thanks. Thanks everybody for taking time out of your day to answer some patient questions. Claire, remind us where you want us to start off. I know you have a bit of an agenda for us.
Yeah, just a quick COVID update. I know we've talked about it several times, but just quick overview. Is COVID a higher risk for TTP patients? And what are your thoughts on the COVID vaccines, one over the other, or just in general?
Yeah, maybe I'll kind of get started. I think what we know right now about COVID, the disease, I think we don't know in general whether TTP patients are at greater risk for relapse during COVID or a greater risk for severe COVID, but there hasn't been any signals at this point that TTP patients are at greater risk of getting the disease outside of those patients who are immunocompromised. Mostly when we talk about patients who are immunocompromised, it's patients who've recently had therapies to suppress the immune system, which obviously are used to treat this immune disease. So I think that bridges nicely into the COVID vaccines, which I think in general we'd say, the risk of the vaccine causing a TTP episode at this point appear to be much lower than, say, the risk of COVID, the illness. Again, even though there isn't a strong link between COVID illness causing a TTP relapse, obviously it can be a very severe disease, and it's currently quite unpredictable outside of immunocompromised patients who could become extremely ill. But I'll hand it off. Era, do you want to talk a little bit about vaccines some more?
Yeah, I think for the most part, broadly speaking, there is, for patients with TTP, there is no known contraindication to getting the COVID vaccine, particularly any which one of them. There had been early on a lot of press regarding a TTP-like syndrome with the Johnson & Johnson vaccine in America and the AstraZeneca in Europe. But these are vanishingly scarce. And I would say unless we have recently given rituximab or some other immunosuppressive like that recently, for almost all of my patients, I am recommending whichever COVID vaccination can be gotten. The risk of getting COVID in a patient with TTP is far worse than the risk of the vaccination.
Yeah, the general idea, so to summarize, we are recommending our patients to get vaccinated.
I would agree with the others in this, that there are no contraindications for vaccine itself. In fact, studies have shown that people who were treated with immunocompromised medications like rituximab are at higher risk of adverse outcomes with COVID, like mortality is higher in patients who are treated with rituximab and other immunosuppressive agents. So these would be the patients who should be vaccinated first compared to the general population. So there are some concerns regarding decreased immune response in patients who are previously treated with rituximab, but I have recommended rituximab no matter what their status is in terms of treatment with rituximab in the recent past versus waiting for 6 months or so. If it is possible, we have tried to vaccinate patients before giving rituximab, but if it's not possible, in most situations, patients with TTP require rituximab more on an urgent to semi-urgent basis. So in those cases, we have went ahead and started rituximab and then asked patients to get vaccinated during the same time.
Excellent. Well, that gives us a good segue into rituximab. So there is a biosimilar, as I understand, of rituximab called Truxima. Maybe somebody can actually pronounce that properly. Yeah. Is it as effective as rituximab? Is there any differences that patients should be aware of? Would you use one versus the other?
I'm not sure if there is any data comparing both these agents. I don't think, at least in TTP, I can say that there is no data. I'm not sure if there is any study which looked at efficacy of ruxience in other diseases like lymphoproliferative diseases, where it is more commonly used. But I have used both agents interchangeably, and most of the time it is guided by insurance companies because they don't cover for Rituxan anymore like they used to consider in the past, because we now have a cheaper medication compared to rituximab, and probably both have the same mechanism of action. So I have used ruxience more commonly than rituxan in the recent years.
I think we pretty consistently refer to the the generic name rituximab to refer to Rituxan, which is the trade name. But more recently, we've had new versions of rituximab that are what are referred to as biosimilars, which is the term used for generic, drugs that are monoclonal antibodies. Since monoclonal antibodies are drugs that are developed by immunizing mice and then generated in the laboratory, it's not the same manufacturing process as, say, other hypertensive drugs or other things like that. So that's why the term biosimilar is used. But everyone should think of this as just a generic version of rituximab. It's the same medicine that's been compared against rituximab and equally effective. And so essentially what's happening that we're seeing across the board is that most healthcare systems are simply interchanging these biosimilar medicines like Truxima with rituximab, sometimes not even notifying us, but this sort of becomes a policy across the healthcare system because the biosimilar medicines are less expensive and have been proven to be equally effective in the diseases where the drug is FDA approved. So we have to remind everyone that rituximab is not FDA approved specifically for TTP. So technically, when you receive rituximab for TTP, it's what we call an off-label use. It's been used in many similar diseases. And off-label doesn't mean that there's anything wrong with it. It just means that it's less likely to be covered by insurance because it's not approved by the FDA. But because it's in common use here in the US, almost all insurance companies will cover the medicine, but sometimes can be extra work to get the medicine approved. Are the other folks on the panel aware that their healthcare systems are interchanging the biosimilars with rituximab?
Yes, they are.
Yes.
Yeah.
It happened without a memo or notes. It just happened.
Right. I know here in Minnesota, we were notified only after the biosimilar replacement had already occurred. So we don't want patients to be alarmed that they're receiving something that doesn't have the brand name Rituxan or the non-trade name rituximab. that they may just be substituting a biosimilar, which is a good thing. It lowers costs of healthcare, and it doesn't bring any risk to patients receiving that. So it's a good thing.
Yeah,
but obviously,
even I have patients that they ask me to get the biosimilar and not the rituximab because of the price.
right.
Okay, well, that's good. And another question as far as rituximab or any of the biosimilar drugs, if a patient is diagnosed with acquired TTP and they're given rituximab, what's the likelihood that they will relapse within a certain period of time? So do you see a decreased amount of relapse? Is it about the same and it's less severe, or how's that handled? And maybe discuss why rituximab is used to treat TTP.
It's a good question. Era, do you maybe want to start with why we use it? And then Anna, since you recently finished our manuscript on how we monitor patients, maybe do you want to take that part of it? And Radhika, why don't you chat a little bit after Anna, if there are things that we haven't covered yet?
So I start. Oh, you are. All right. Sorry.
Yeah, too many three-letter names here.
Yeah, that's right.
So in immune TTP or an acquired TTP, this is an autoimmune disease in which the immune system, for some reason, has decided to target this one enzyme, ADAMTS13. And over the course of several years, what has been found is that one, plasma exchange is the treatment of choice. And then when steroids were added on top of that, even before they knew what was the true nature, the true pathophysiology of TTP, this shortened the durations of TTP. And then along the years, through a lot of research that has been done, particularly in Europe, by adding rituximab, by targeting what's the ultimate problem with this disease, is that there's this inhibitor. It's not a congenital absence of ADAMTS13, but an autoimmune mediated disease, that by giving a medication like rituximab, particularly early on, this improves the likelihood for remission and decreases the likelihood of relapse. I think sound about right?
Sounds great.
Yeah, it's right. So the second part was how long and if the patient relapse on rituximab. I'm correct?
Correct.
How long? Yeah. Okay. So as Ada said, when you give rituximab, we are trying to fight for this antibody and inhibitor to ADAMTS13. So the effect of rituximab lasts approximately 6 to 9 months. Some others say a little less. So depend if your antibody or inhibitor, so if the rituximab is suppressing the inhibitor and the effect of the rituximab goes away, and the inhibitor is still persists. So the risk of relapse in these cases will be after 6 to 9 months. Some patients receive rituximab, and after 6 to 9 months, the inhibitor was suppressed, and probably in those patients will not relapse. But we need to monitor because we don't know if the inhibitor is going to come back or increase later on. I hope I answered the question.
I think so. Radhika, any other thoughts on use of rituximab and how you monitor patients after a TTP episode?
Yeah, so I guess to summarize what has been discussed, so we can use Rituxan in 2 situations in TTP. The first is with the acute presentation, so when patients come in with TTP for the first time. And in those situations, when we use Rituxan, it tends to improve outcomes in the short term and also help in preventing a relapse of TTP in the long run. And in the other situation, we use Rituxan to prevent an acute TTP from occurring for the second time or the third time. So we call this as preemptive therapy, where patients don't have clinical manifestations of TTP as of yet, but their ADAMTS13 level would be going down when we are monitoring them in the outpatient setting most of the time. So in those cases, giving Rituxan will prevent that or delay that acute episode from happening. And typically we monitor patients after their first episode. When they're discharged from the hospital, we see them closely in outpatient setting in the clinic and monitor their blood counts as well as other markers which indicate red cell destruction, as well as RMTS13 level, which is the enzyme that is deficient in TTP patients, or find an inhibitor or antibody that is directed against this enzyme.
Great. Yeah, and I think it's important to think about, this medicine has been in use a long time, so it's quite familiar for folks. I think in general, we think of it as a medicine that is unlikely to hurt patients. There's some patients who have reactions to the medicine, but overall, it's certainly much easier than a lot of chemotherapy medicines that have been used before this medicine came around. But particularly during the COVID pandemic, it has at least made us think twice about whether the medicine could put patients at risk for COVID-19. So it has been a more sort of balanced approach, I think, in it. Anytime we use medicines that suppress the immune system, there are risks of infection. And in particular, the last few years with COVID-19, that's been part of our discussion. I just thought I would chime in that this medicine differs in comparison to another medicine that has a similar name called caplacizumab. They both end in MAB, which is an abbreviation, monoclonal antibody. So caplacizumab is a recently approved medicine. Technically, it's the only FDA-approved medicine for TTP. So while the medicines have a similar end to their name, they're used in different ways. This medicine is used on a daily basis to prevent TTP from coming back, which it happens in about a third of patients within the first few weeks after an episode, and can protect people while they're in the hospital and get them out of the hospital faster. And is a new medicine for TTP. So some people are commonly using it, others are not quite as familiar, and I think all physicians are a little bit cautious in starting to use new medicines. So the medicines sound similar, but are used in two different ways. And we really kind of think about treatment for TTP this way. We use treatments like plasma exchange and caplacizumab as treatments for the acute illness when people are sick and in the hospital. And then medicines like rituximab and prednisone, which suppress the immune system to keep people in remission. And there's been a lot of interest in our US TMA group in trying to understand which patients end up staying in remission a long time compared with those patients who don't. And I think overall, part of the challenge of this disease is we can't really predict very well who will stay in remission long term. And I think that's an important part of our research moving forward, is trying to understand, are there better ways we can predict who will stay in remission a long time from rituximab? And who are the people who might benefit from either a different treatment or more intensive monitoring or treatment? So we're hoping that a more intensive study that will be opening up throughout the US TMA sites will help shed some light on that. And we're hoping that we can develop new blood tests and strategies to try to help figure that out. Who are the patients that get a long remission after rituximab, so that hopefully we can get more and more patients to that benefit, because we realize that the threat of relapse is what really causes a lot of anxiety on everyone's part. We worry about our patients relapsing, and we know patients worry a lot about relapsing.
Good.
Yeah, as a reminder, if we are not treating with rituximab in the acute setting, it's better to get vaccinated for COVID before giving the rituximab, since decrease the immune system. So it's a reminder what Radhika said earlier.
Right, and I think we've had a lot of patients have this discussion here, is that before COVID-19 ever happened, there were studies done looking at what happens to people's ability to respond to vaccines after rituximab. And so a group of patients were studied and showed that some people could have quite a delay of several months up to a year until their body can normally respond to a vaccine. And so when we feel like it's safe, we have recommended that people get the vaccine first and then get rituximab. Now, the problem is not everyone responds to vaccines and treatments the same way. So we're really kind of generalizing here. We certainly do see patients who get medicines like rituximab and other immune suppressants and still make responses to vaccines. So what we're trying to do is just give people the best chance of having the best response to the vaccine. But sometimes we just have to do with it the best we can. And sometimes the risk isn't worth the delay.
Okay, we've got a question here about disease processes that are related to TTP. So as we know, acquired TTP is an autoimmune process. Are you more likely to get another autoimmune disease if you have TTP? And specifically, are you more likely to get antiphospholipid syndrome? And is it related to TTP?
Sure. Who wants to start? Radhika, do you want to maybe lead us off a little bit? Great.
Yeah, so certainly we have seen patients with multiple autoimmune diseases, and we have seen patients where they have had multiple family members with autoimmune diseases when they presented with TTP. And most commonly, we see lupus as a common autoimmune disease that has been associated with multiple other TTP-like conditions. But we kind of don't know if there is one particular mechanism that would predispose patients for multiple autoimmune diseases. I think, I guess probably we need more studies in looking at these underlying mechanisms, and maybe some kind of genetic predisposition that leads to multiple autoimmune diseases, which can present at the same time or develop over the course of their lifespan.
Anna, do you want to
Well,
chime in?
I was going to say, I cannot think of any of my patients. So there is, as Radhika said, patients that they have different immune disorders. I can think the relation between lupus and TTP, or rheumatoid arthritis and TTP. None of my patients has lupus anticoagulant or antiphospholipid with TTP. My experience, I didn't see. Doesn't mean that probably you guys had patients, but we cannot predict which patients with immune disorders are going to develop TTP, or just the opposite, if a TTP patient will have lupus. But there have been some reports that some patients with TTP later on was diagnosed with other immune disorders, and the most common is lupus.
Yeah, I would agree. It probably comes down to some degree that there's a similar demographic in that women and people of African American descent are overrepresented in both TTP and in lupus. And so that may be part of it. The other thing is that antiphospholipid antibody syndrome is a very rare immune disease, just like TTP is a rare disease. So just by chance, having both diseases it's not impossible, but it'd be pretty uncommon. So it's not a common combination we see. It certainly can happen. And antiphospholipid syndrome can rarely cause a similar disease process of low platelets and blood clots and the small blood vessels of organs. So they can mimic one another too. So that can be a challenge to pull apart the two diseases. But certainly we do see in general in medicine that people with one immune disease seem to be prone to developing other immune diseases. So it may be that their immune system is simply a little more mistake prone to develop autoimmunity. Did you have other thoughts, Era, about this phenomenon?
I think the first question, like Dr. Antun pointed out, we see if someone is with TTP is going to develop an autoimmune disease, it tends to be lupus. Although it's interesting enough, I think we don't see, although the other way around, I have to say I have not seen a patient with known lupus later developing TTP. That I think I can't really recall that. And I think, like Dr. Mazepa said, I agree with that, is that, at least within the European and American literature, many of them, if you read this, they'll talk about how it's our Afro-American or Afro-Caribbean or our African-American patients are the ones that are at higher risk. And that also goes, like you said, in step with patients who are at also risk for other autoimmune diseases. But after that, aside from that, I don't think we quite know what are all of those risk factors that it takes in order for the immune system to lose what we call tolerance to self. I think that's still a huge area that we just don't know the answer to that yet.
Great.
Okay, and we have a couple of recently diagnosed patients that have written in, and they just wanted to know what the typical course of treating an acute episode of acquired TTP is. So if you guys just want to talk about like what your frontline treatments for a newly diagnosed patient would be, and then what are the long-term effects of the medications used? Specifically, people are asking about the steroids and how long it takes to kind of return to normal. So if we want to talk about the long-term effects of having TTP.
Great. Dr. Metjian, why don't you give a start to this one? And there's plenty to talk about here, so we can kind of go around the table as to what we might expect.
There's a lot to unpack. So the first question is, what's the standard of treating TTP?
Acute episode.
Yeah. And I think, the vast majority, I think most people who treat TTP would say, first and foremost is starting therapeutic plasma exchange immediately. We view TTP as a hematologic emergency, and immediately starting, getting that central line placed, starting someone on plasma exchange. At the same time, I think most of us will also say that the use of high-dose corticosteroids, in which I'm sure I'll let someone else answer that. Yes, there is, it's cheap, it's easy, it works well, but yes, there is the devil to be paid with that. And then, currently, the ISTH guidelines are now recommending the use of upfront rituximab in the use of TTP. And at least as my practice is, all patients with TTP, I will put on caplacizumab immediately. As soon as we're thinking that the diagnosis is TTP. And that we consider that course of treatment, particularly plasma exchange, until the platelet count is greater than 150 for 2 days in a row. And then we continue on with the caplacizumab for at least for 30 days after the last plasma exchange, as well as continuing on with the steroids and completing the course of rituximab. So that first 30 days are pretty intensive. And by doing this is where we've been able to reduce the mortality of a disease that was almost 100% down to, I'd say, realistically down to about 10%. And then I'll let someone else take over where we go from there.
I'll go last. How about that? Dr. Antun, you want to talk a little bit maybe more about, once people are out of the hospital, what sort of your practice and starting to follow patients and what they can expect during that first month after they get out of the hospital?
Yeah, can I make some comments from Ara and then I continue with the post-discharge? So I think one of the important points, and he mentioned that this is an emergency, is to start treatment right away. No delay. And the idea of that is because of the mortality. Before in the 90s, I believe it's in the 90s, we know that if we don't treat a patient with TTP, the mortality is 90%. or approximately 90%. So this is the idea to start treatment right away without delaying. Each patient is different, but we want to treat all early and prevent that high mortality. The second, and I think they asked about the corticosteroids or prednisone or dexamethasone, or you want me to leave it for you? So we try to taper the steroids, and this is one of the recommendations for the consortium in less than 1 month or in a month because of the side effects. And the side effects of the steroids are multiple. Starting from can cause diabetes or increase your sugars, the high blood pressure, retain fluids, long-term can cause osteoporosis. I know that I am forgetting muscle weakness. So multiple side effects, and this is the idea why we want to taper as soon as possible. And then I move to once the patient is treated, recovered, and is sending home, we want to monitor the patients, especially, first of all, if they are on cabazitaxel, we want to check labs every month, and every week until we know if the cabazitaxel can be stopped or how long to continue. If a patient is not on cabazitaxel, the first month we check labs and we see the patient every week, check and be sure that the platelets are stable and they are not dropping or there is no worsening anemia. And we check Adams TIA13. And if everything is stable, after that, we see the patient. So every month for 3 months, and then every 3 months until we know that the Adams TIA13 is good. So I will stop there. I know that Radhika and Marshall can comment or something that I forgot.
I can probably talk about long-term complications in patients with TTP. So I would say that I guess like we follow the same practice at my institution as well for management of TTP in the acute setting. And I would say the first few weeks or first month is the most intensive period where a lot of treatments are given. Patients are very anxious about when they would stop plasma exchange and get out of the hospital as soon as possible. And usually within first 3 months or so, their disease is stabilized, unless if patients are having refractory disease. Most of the studies that were done in TTP have focused on acute complications or within the first 6 months of treatment, because it was mostly a fatal disease. About 90% of the patients were dying because of TTP. So the earlier studies did not focus much on long-term complications. We are just starting to learn about these long-term complications in TTP patients. And very few studies are available in this area. And we are learning that a lot of cardiovascular complications occur in the long run, as well as psychological problems, lots of anxiety and depression that occur over time in these patients. And studies are also showing that there is increased risk of hypertension, kidney problems, and other cardiac problems and stroke in these patients. So it's important to have routine follow-ups with primary care physicians or hematologists, and to make sure that you have a healthy lifestyle, exercising, eating healthy, in order to prevent these long-term complications.
Great. Yeah, I think sort of to summarize is that, yeah, that first month or so is pretty intense in terms of monitoring and making sure patients stay in remission. I think in terms of side effects from prednisone in particular, it usually does take a few months before people kind of feel back to their usual level of energy and feeling back to their normal selves. So I think most people should sort of anticipate that by the time 3 to 6 months rolls around, hopefully you're feeling back to your normal self. I think what we're, as everyone's mentioned, that some of the longer term effects of the disease, its effect on the brain, and the brain does seem to be very sensitive to this disease. People, we can anticipate that generally there's recovery after TTP, but we don't really understand yet how the disease behaves long term. We do know that patients have reported to us that their thinking and memory and emotions are not the same as before the disease. And we're doing a small study now and intend to do a larger study soon to try to understand what causes these long-term complications so that we can treat them better. But I think for now, for those patients watching, I think it's important to understand these are known complications of the disease. We can try to help you through it, but at least there's some solidarity there that other patients are experiencing these, and we're trying to understand them to try to prevent and treat them. But most of the focus on this disease for the last 20 plus years, has really been on how do we get people through the first few days in the hospital. Between plasma exchange, which was shown to benefit patients clearly in the 90s, and then this more recent treatment, caplacizumab, which I think we kind of think of as a plasma exchange booster or almost plasma exchange in a syringe, has really made a big impact on mortality, so that luckily today, few patients die from this disease, so that now we can really focus on the long-term health of patients. I think we're very thankful that we can turn away from patients dying from this disease to really study these long-term problems. It isn't, nothing's perfect in terms of treatment, but the strides that have been made the last 20 years are impressive. Intensive monitoring, side effects from prednisone for the first few months. Dr. mentioned that is calling attention to something we've forgotten. Go ahead, chime in.
Sorry. I do want to, like you mentioned it, and it is not. I mean, for many patients afterwards, there is a depression or almost a PTSD-like feeling, because this is a disease no one's ever heard of, let alone most people have difficulty pronouncing. And it is such a bewildering experience in that first month that, many of my patients have just, have had a panic, a worry, a depression of like, oh my God, what if this happens again? And it is not that it's normal, but it's not a shock. It's not a surprise. I mean, for what people have gone through, it's expected, and it's not something that it's not something that should be ignored, and not something that is like wrong with a patient if they are experiencing this. So I just wanted to throw that out there.
Yeah, and I think that's a great point. And I think the reality too is that the standard of care for this disease has changed, both with new medicines, but also with understanding that we shouldn't just let patients go off to their primary care doctor after remission is achieved for a few months, which I think has been the standard of care in the past. But the reality is that now that we're understanding that there are tools we can use to help predict relapse. No blood test right now is particularly great at it, but I think we get a sense for when relapse might occur, if it will occur. And so as opposed to discharging patients from the clinic after a couple of months of remission, now we really encourage people to follow blood tests and come back to the clinic on a every 3 to 6 month basis to try to understand the disease is important. Those are some big changes, but we do want everyone to understand that we expect a lot of intensive follow-up and close monitoring those first few months, and side effects hopefully wane, particularly from the prednisone, until remission sets in.
So sorry. I was just going to say, you've discussed the follow-up that's needed for these patients and the fact that they may see these psychological alterations and impacts on their brain. What do you guys do for those patients to help help them get through that? Is there a referral system, or is there medication you guys look at? What coping strategies?
Welcome. So one thing that I want to mention is sometimes probably the patient doesn't realize that it's depressed, but it's something for the family to be aware and communicate with the physician how is the change in the mood for the patient. And if we detect that the patient is depressed, my first thing is to send probably for mental health or for some support with psychology to evaluate and see how much treatment needs or which type of treatment needs.
Yeah, right. And I think right now, say depression that occurs in a patient with TTP isn't treated any differently than depression in someone who doesn't have TTP. Really, the mainstay of treatment, at least in the beginning, is therapy with a psychologist and addition of potential first-line medicines for treatment of depression. We don't have great treatments for some of the memory problems. And I think part of that is we just don't necessarily understand why they happen quite yet, but I think that's on the horizon. In stroke patients who've had problems with cognitive tasks, memory, sometimes working with an occupational therapist can be helpful. Sometimes just having formal cognitive testing done can be kind of validating, help people understand what are the problems I'm having, and so then I can develop a plan to work around those problems I'm having, like short-term memory. And then I think the other thing is that meeting other patients with TTP and participating in support groups can be really helpful. We have a support group in Minnesota that's been on hiatus for COVID, but the USTMA has put on a national patient meeting in August the last couple of years, and our plan is to proceed with the patient meeting again this coming August of 2022, hopefully in person. If not, we'll do it sort of a hybrid virtual meeting again. But I think, sometimes it's just really great to meet other people who are going through the same thing, especially with a rare disease. Radhika, how about you? Do you have a particular treatment strategy for patients after TTP?
Yeah, I guess it has helped to set some expectations. So whenever I see them immediately after discharge, most patients, I guess I can say that universally, almost all patients who are discharged from the hospital from TTP, and for about 3 to 6 months, it's okay to have fatigue, memory problems, and anxiety. So I think it's a big relief to talk with patients about these expected complications in the acute setting. And as Dr. Mazepa has mentioned, it's helpful to talk to other patients who have gone through this and be connected with them through support groups that, there are multiple TTP or TMA support groups that you can be part of and talk to each other and know how the expectations are like at each phase of treatment. Or most of the times we have seen that these symptoms tend to get better with time. So if you have symptoms, I think it's okay to talk to your provider about anxiety and depression. There's nothing wrong about it, and nothing wrong in seeing a psychiatrist to seek help. And usually in the short term, especially if the symptoms are affecting your quality of life, I have seen patients benefit from anti-anxiety and antidepressant medication. So I usually send them to a psychiatrist if their symptoms are severe.
Great, thanks. Any other thoughts on this? Dr. Metjian, what's been your strategy with patients who struggle with this long-term thinking, cognition and depression, anxiety?
I think I agree with what you said before. I think neurocognitive testing is, that's something that we're now doing, I think, with most of my patients, getting an MRI, neurocognitive test, just see what their baseline is. And as you mentioned, it's having routine and regular follow-up with patients with TTP and making sure, I mean, because this, many patients have a sort of a once bitten, twice shy where, the prayer is, oh my God, please let this not be another relapse of TTP, and making sure that that it's okay to get a CBC, it's okay to get retested, and even if it's normal, that's fine. We can do this. Let's, these are just simple blood tests, and if we act on this early enough, and I think that for some of my patients really helps to alleviate the anxiety, the stress of worrying about a relapse. And I think, as Dr. Antun pointed out, getting patients sort of like if they need help with things like physical therapy, occupational therapy, especially if they've had strokes or more significant neurologic complications from TTP, and just knowing that, look, there's at least things that we can try doing. And definitely acknowledging if there is depression, if there is a PTSD-like component to this, acknowledging it and, sort of encouraging patients that it's not a badge of dishonor to say, look, I'm depressed. There's not something wrong with a person, to say, I need help with coping with this, because they've probably been through a lot, something that, the people on this panel will never go through, knock on wood. So I just think close follow-up and letting them know that there is this community. I let many of my patients know about the USTMA, especially the Ask the Hematologist, especially when I get questions from patients, from doctors with TTP patients elsewhere. And that just knowing that this isn't, there's no need and there's no heroism in suffering in silence.
Right, and you brought up a great point about part of the benefit of being connected with a clinic and a hematologist long term is during those times when you start to feel anxious about a relapse, you're feeling ill and not sure, is this the common cold or is this a TTP relapse? Reaching out for a simple blood test sometimes just really helps put the brakes on some of that anxiety. Great, Claire. Are there other questions that we can help answer tonight?
Yeah, so here's a good one, actually one that I wanted to bring up too. Given the national blood shortage, can patients with TTP donate blood?
Yeah, it's a fair question. Dr. Metjian, did you want to start? I saw you nodding there. Go ahead.
I'll say yes. Presumably this is if someone is in remission. Obviously, during the acute phase, the simple answer is during the acute phase, heck no. No, that's just a bad idea. But if someone has been in remission, there is, I don't see there being a reason not to. Now, the issue might be if you have received plasma products. Marcia might have to help me out with this in terms from a blood bank issue. There may be a restriction, but from a altruistic point of view or from a health perspective, if someone wants to donate blood, if someone wants to donate plasma, there is the prior diagnosis of TTP is not an exclusion, in my opinion.
Right. Yeah, the FDA sets all the rules for blood donation. And then what happens is on top of that, individual blood banks can add to restrictions. They can't loosen what the FDA states in terms of the rules for blood donation, but they can add restrictions. Now, TTP is not a common enough disease that most blood banks will have, in particular, a policy. You will have to designate that you have received blood products in the past. My recollection is, I think you have to be a year after a blood receipt of a blood transfusion. But the easiest way to know for sure is if you're interested in donating blood, call your local blood bank and ask them your question. There aren't any, as Dr. mentioned, there's no specific rule against giving blood if you've had TTP. So ultimately what will probably happen is your question will be moved up the chain to the blood bank doctor in charge of the blood bank who will make the ultimate call. So it's possible that people may hear different answers at different blood banks. I think in the end, components of blood can be given, particularly red blood cells may be given from patients with TTP, but potentially not plasma.
Yeah, I think even from the treatment point of view, there is no contraindications if you receive treatment, but yeah, it's more restricted for the blood bank requirements more than TTP diagnosis, history, or treatment.
Okay, so it sounds like it's just kind of a local question for your blood bank to see if they have any feelings, but there's no, you wouldn't end up giving somebody TTP if they got your blood. There's no inherent risk there. Okay. The next question has to do with congenital TTP. And the patient, well, the person writing in has a son who's on COAT. And if someone would discuss why COAT's being used to treat congenital TTP and maybe how it's a little bit different than the acquired version. She had a physician refer to it as a dirty kind of drug. And she's just trying to make sense of that.
Go ahead and start, Dr. Metjian. Yeah.
I mean, I wouldn't say, and it's probably, it's not, let me work backwards. It's not dirty. And it's a very, from the doctor perspective, it's what COAT is what we call a low or intermediate purity. Not that there's like dust and hair and corn chips in there. It's just the fact that, you know, so COAT is what we call a plasma derived concentrate. It's where you've taken plasma and you have sort of concentrated it down, and where it's high in something called factor VIII and von Willebrand's factor. It just so happens to be high in Adam TS13. And, you know, and these products can be virally, they can be sort of purified, so to speak, in terms of bacterial or viral contamination. But we call it low purity because unlike some of the other agents that are used for hemophilia, which are recombinant and are 100% pure factor VIII, this has many other plasma proteins in it. So dirty is a little unfortunate of a term. And so, yeah. So does anyone else want to talk about the congenital part? That's pretty straightforward.
I can start. So the difference is we have the congenital and we have the acquired TTP. So congenital is when we born with low Adams TS13, and acquired is when we, during life, we develop an antibody against the Adams TS13. So it's important to make the difference once, because the treatment is different. For congenital TTP, we give plasma because we provide the patient with Adams TS13. When in acquired, not only that we need to exchange to take some of the antibodies and give some Adams TS13, but also we need to treat with immunosuppression the presence of this antibody that is not letting the Adams TS13 to work. Now they are in clinical trials, the recombinant Adams TS13 that is being used for patients, but in clinical trials, not yet approved in patients with congenital TTP, and is recombinant, means that has been produced not from plasma from patients, and is until now looks like it's working well. But I will leave Marshall and Radhika to comment something else about.
Any other thoughts, Dr. Gangaraju?
Yeah, I agree. I think Dr. Antun has elaborated the differences between management of congenital and acquired TTP because the mechanisms are different. Even though the common deficiency is Adam TS13 deficiency, I guess like with congenital, you don't make enough enzyme, whereas with the acquired form, there is no problem with synthesis, but it is inhibited by the antibody. So we commonly treat the congenital form with plasma infusions. At least in the past, that was the main stay of treatment. And now we have a recombinant form of ADAMTS13 that is going through different phases of clinical trials. So hopefully it will be available soon for use in a much larger scale.
Yeah, and I think hemophilia is actually, in a sense, is a nice way to think about congenital TTP. They're both diseases where people are born without an important blood protein. In hemophilia, people are born without blood clotting factors, so blood clots tend to be less effective, and so bleeding is the symptom from the disease, whereas in congenital TTP, the missing protein helps prevent blood clotting. So they're, in a sense, related diseases. And so in the beginning, hemophilia was treated with plasma too, but the problem was that you had to give so much plasma, it wasn't very effective. So the next strategy was to use chemical techniques to concentrate the missing protein. And CoAID is one of those. And as Dr. Metjian mentioned, what happens is when you use chemicals to concentrate a protein, other proteins come along for the ride. And of the different forms of concentrated factor VIII, CoAID seems to have the highest level of ADAMTS13. So it's the one we use the most. And so the primary advantage of CoAID over plasma, both for hemophilia and for congenital TTP, is that it's just a much smaller amount of medicine. We're really limited in congenital TTP, that we just can't give enough plasma to really make the enzyme level go back to normal. So then the next phase in hemophilia was to develop recombinant protein, and that's where we just synthesize, we just make the protein in the lab. And the same thing is now happening with congenital TTP, where recombinant or made from scratch ADAMTS13 has been developed and is in phase 3 testing now. So we hope that'll be even more effective than CoAID. And I have a couple patients with congenital TTP treated with CoAID who've done really well, and really appreciate the fact that they can give it at home. It's much nicer than having to come into the clinic to get plasma. And it's obviously a lot less fluid than getting plasma. So the time in for the infusion is much smaller. So certainly the British experience with this drug and related, there's a European similar drug, has been very positive. And I think our experience with CoAID has been quite positive as well. But I think characterizing it as sort of a dirty medicine that is really disingenuous. What we really are saying is that it was developed for a different disease. It just happens to also work for this disease. This drug has never been known to, say, transmit diseases or be impure in any other sense. That just happens to have other blood proteins and from the manufacturing process. So I think don't think of it as a risky medicine. It's simply a medicine that's repurposed, like so happens so often in medicine, where a medicine developed for one disease is used for another.
Yeah, I think Dr. Mazepa actually brings up a great point that it is very convenient to use compared to plasma, which requires frequent visits to a clinic. And most of the time, congenital TTP patients are young and they go to college and are in jobs. So it's very difficult for them to come for routine clinic appointments to get plasma infusions periodically. So it's much more easier to give the concentrated form of the factor compared to regular plasma infusions.
Well, thank you. Thank you for the explanation. Thank you everybody for joining us tonight. Thank you to our physicians for logging on, answering all these questions. If your question was not answered and you still want it addressed, email us at admin@ustma.com or ustmaconsortium.com, or you can write it in on Facebook and I can messenger questions back and forth. So Thank you, everybody, and thank you for joining us.
Thanks, everyone. Have a good night.
Thank you.